Hi, everyone. Thanks for coming out over Saturday. Who here had headaches as a child? Who has a child with headaches? Good. So hopefully this will be useful for you. Let's see how it goes. So, when you go to the doctor has to try to figure out why you have headaches. And this is something that every doctor should have in their office because all headaches fit into one of 4 categories. And that helps because if you just have a list like this, nobody can memorize a list like this. But if there are just specific categories, life is pretty easy. So this is one category where you have no headache. This here is how bad your headache is, and this is time measured in days. So if you have no headache, a really bad headache, you go back to normal. You have no headache, and you have another really bad headache. What's that going to be? Migraine, right? Because in between your migraine attacks, you go back to normal. If somebody has headache all the time, and every once in a while they get a bad migraine, that's called chronic migraine. So in my headache clinic and in George's headache clinic, that's who gets admitted to the hospital. People who have headache all the time and then get migraines in between. This is the terrible pattern, the one that makes us all shudder. When you never had headaches before, the headache gets worse and worse and worse. That's going to be chronic and progressive, and that's what people who unfortunately have brain tumors, that's going to be their pattern. And then some people never had a headache, and then boom, they get a headache for the first time in their life. And there's a question mark there. Those are patients who need some work on rather rapidly. But if you think about headaches in those categories, I leave this in the waiting room. People check off what category they have, and it's pretty simple. So kids do the same thing. If a kid has a virus, they might just have this one. If somebody has migraine, they're going to have this one. God forbid somebody should have this one. And unfortunately, some of the children and teenagers that we see in our place had migraine before and have chronic headache. Come on, you can do it. There you go. So, kids get migraines too. As we said earlier, boys and girls before puberty are about the same for their first one. If you've had your first one before puberty, 50% of the time you'll never have them after puberty when you grow up into adulthood. If unfortunately the headache comes after puberty in a girl, most likely that girl, as she becomes an adult, will continue to have migraine headaches. So the reason I show you this one is this is the classic migraine. In this one, you see that the person has headache only on one side, right? You also see that it says it's nausea, light and sound sensitivity. The problem is if you stick to this very strict criteria, you will miss most of the kids who have headache, because kids have bilateral headache more than 80% of the time with migraine. Kids may get pain under their eyes where their sinuses are, and we call it sinus headache. Kids may even have pain in their neck and not have it one-sided. So location, location, location is a good real estate rule. It's a bad rule in treating children and adolescents who have migraine. The other thing is if you ask a teenager to describe your pain, they're not going to say words like throbbing, knife-like, vice-like. They're going to say hurts. So if you're relying on descriptive words, the kids won't give them to you. So the most important thing to do is use that roadmap that I showed you at the beginning. If you have that right pattern, it's probably going to be migraine. So, there you go. If you have an aura, it's easy. So the aura, if you notice, this poor person has these wavy lines that go all the way to the outside. That's a migraine aura. Unfortunately, children and adolescents who have migraine, only 10% of them have this. So 90%, 9 out of 10 people, kids who have migraine, don't have this aura at all. Okay? Despite that, kids will tell you, you know, I should have known it was going to be a migraine day. The day before I was yawning, I was tired even though I had enough sleep. I maybe was more irritable, I had a feeling of dread. So After a while, some of the teenagers say, I know a migraine's coming, and boom, they need to be treated as soon as their headache starts. So, it's that pattern, the pattern I showed you. It's severe. Somebody with a migraine, a full-blown migraine, cannot exercise, cannot read. Now, if you can't exercise and you can't read, what else can't you do? Go to school, or be successful in school. Because all kids do in school every 45 minutes is run up the stairs to the next class. And they're required to be reading. So, if you have a lot of migraines, you're going to have a lot of school absence. The location doesn't matter. Most kids don't have an aura. The autonomic symptoms is nausea, vomiting, light, sound sensitivity. Say that, I say it in one word. Do you have nausea, vomiting, light, and sound sensitivity? So if you have the right pattern at nausea, vomiting, light, sound sensitivity, that's a migraine. Family histories, I asked the question. George showed you earlier that 50% of adults don't know that they have migraine, even if they have migraine. So if you ask the question to somebody, is there a family history of migraine in your family? 50% of the people who really do have it won't know, so they'll say no. So the better question is there anybody in your family who has a lot of headache? Yeah, please describe. And if they tell you nausea, vomiting, light, and sound sensitivity, boom, you've now identified another migraine. So, the reason to show you this one is I want you to focus on this poor child's pulling his hair out at the top. You see that? The reason why I show you this one is that treating migraine is a race to prevent your hair hurting. Who here with migraines gets scalp tenderness if the headache goes too far? Okay? There's a doctor word for that. It's called allodynia. Allodynia means something hurts that shouldn't hurt. Your scalp gets sore. When your headache has progressed to the point where your scalp gets sore, that's going to be a headache that's going to be much harder to treat. The usual good drugs that we call triptans don't work so well once you have allodynia. So even with kids, treating the kids is a race to prevent allodynia. Does that make sense? So, you got that pattern. If you have the bad pattern, it could be a brain tumor. I have to tell you that every single new patient who comes to see me is convinced they have a brain tumor. That's why they're not there to see me to treat their migraines. They're there to be convinced that they don't have a brain tumor. So it's very important to tell people many times during the visit if you don't think it's a brain tumor. So if the pattern is the migraine pattern, it's not going to be a brain tumor. Unfortunately, if someone does have that progressive pattern that goes straight up, that would make me worried about a brain tumor. What else goes with a brain tumor? It's worse in the morning. When you bend your head forward, it's worse. When you cough or you sneeze. Why is that? I'll explain. We all have pressure in our brain. In between my two hands, the pressure is not felt. People cough, sneeze, they do things that might increase their pressure a little bit. It never reaches symptomatic. If you're having increased pressure from a brain tumor, any little thing is going to make it symptomatic. So that's why the headache's worse in the morning, and it's worse when people bend their head down and stuff. Now, when you have a migraine, those things may happen, but it's not all the time. That's the pattern for brain tumor. Cool, huh? Now, that quick pattern, that acute thing happens in viruses. If somebody has a skin infection and they get blood infection from that, if they have meningitis, that's going to give them acute headache. That's not hard to diagnose either. Which one's that going to be best? What's the name of that? Acute, correct. Now, there's one acute headache that's a medical emergency. If somebody gets that, you should make the doctors quake. Somebody never had a headache, or they've had a headache before, and in an instant, their headache makes them fall to the floor. That's called thunderclap headache, and that could be a bleeding. So someone had a little aneurysm that ruptured. Does anybody have a family member that had that? Right. That headache is very, very different than all the others. So I'll get a lot of people who come to me to say, Aunt Matilda unfortunately died of an aneurysm, and now my child has headaches once in a while. Could that be an aneurysm? So then you say, wait a minute. that described what happened to Matilda. She was minding her own business, and she fell to the floor. That's a thunderclap headache. That's different. So that one's going to be which pattern? Correct. Now, chronic headache is what fills up headache clinics, and even kids' headache clinics. So 2% of the general population have more headache days than not. If you go to a headache clinic, there are some headache clinics that have about half of the people with chronic headache and half don't. And then there are headache clinics for those that fail the headache clinics, and they're going to be 100%. So if you work in a headache clinic, you think everybody has chronic headache, but it's really not true. And that's going to be this pattern, where you have headache all the time, and what doesn't show up in the picture is that there are migraine spikes in between, and that's going to be called chronic migraine. The whole point of getting your migraines treated when you're young is to prevent this from happening and filling up your place, right? So here's general advice for your treating doc. Take your time. I think taking care of headache people, it's not a boilerplate thing that you do in 5 minutes and you're out the door. Every headache patient has their story, as we heard before today. Everybody needs to be listened to, and everybody needs a chance to tell their story, because every headache patient is a little different and deserves their own tailored plan. I think every headache patient deserves the right diagnosis. If you go home with the wrong diagnosis and continue to suffer, there's sometimes weeks, months, or years where you go by until you get the right treatment. Does anybody here have that? A lot of people. So the duty of that physician is to make the proper diagnosis. Now, assessing disability helps the physician figure out how intense to treat. If someone's not going to work anymore, not going to school anymore, and they tell you they're about to lose their job because of their headache burden, that's somebody who needs a lot more than someone who says, I'm worried, but I get these headaches maybe 2 or 3 times a year. Does that make sense? So how do you assess disability? I call it absenteeism and presenteeism. Absenteeism means how many days are you absent from work or school because of your headache. That's easily measurable. Presenteeism is the more common. How many days do you go to work or school but you're not functioning at 100%? That's a very important thing to document, because presenteeism is what loses you your job. You can get FMLA if you need to be protected from your absenteeism, but not from your presenteeism. Presenteeism means you have 2 people sitting and working side to side, and your colleagues got to pick up your work all the days you have migraine. You come to work because you're dutiful and trying your best, but it's just not working. That's the person that gets laid off or fired because of their migraines. So when describing disability, it's absenteeism and presenteeism. And when you're monitoring if you're getting better or not, I use green dots and red dots. Green dot means you've had a headache, but you're okay. A red dot means it's a bad day. You can use another dot for days that you were present but not accounted for at work. And then you can follow and see if your absenteeism and presenteeism has gone down. Now, SNOOP is what we do as physicians to look for those needles in a haystack. I'll describe that. These are the worry signs that us docs use to figure out who's got something horrible. So the first is systemic symptoms. If a young woman in her 20s loses her period, that makes me worried that something's wrong. If a child stops growing, that makes me worried that there's something wrong. Neurologic symptoms are obvious. If someone has a new neurologic finding, their gait changes, or they're walking funny, or they can't find the words, or they have a facial droop, those are things that would make a physician worried that there's something underlying terrible, not just plain alarming. If the onset is abrupt, we talked about someone who falls down right away, that's worrisome. If someone never had migraines and they're 50 years old and now they start getting migraines, we're worried, because migraines are a disease that usually starts in the first, second, and third decade of life. And the most important one is the last one. If things have changed, okay? If 30% of the world has migraine, that means 3 out of 10 people who have a brain tumor had a history of migraine before. So listen carefully and tell docs. And for you guys, make sure your docs listen to you. If your headache history has changed, that's something to work with. So that spells the word sleep. So the doctor takes the history and does a physical exam. If there's no red flags, and if the pattern is right, there's autonomic symptoms, it's migraine, there's no need for any tests. But if you snoop and something comes up abnormal, then there's a need for some tests. Make sense? So what do? So I think the big mistake that's done is that doctors undertreat acute migraine. Remember that when you're having a migraine, your stomach doesn't empty right. So you may need more medicine to go in for a little bit to trickle through and work. Does that make sense? So these drugs, like acetaminophen, ibuprofen, naproxen, I should have changed that. Not use proper doses, use higher doses. So pediatricians should refer to me, and I'll often get linebackers who are taking one ibuprofen for their migraine. Okay. So use higher doses if you're going to use oral treatments for your migraines. Triptans come as pills, they come as nasal sprays, they come as shots. Shots, you don't have to worry about your stomach. Nasal spray, if done properly, you don't have to worry about your stomach. Shots give you more side effects than nasal spray, and nasal spray gives you more side effects than pills. But pills are not as reliable, because if your stomach isn't emptying and you wait too long, the pill's not going to work. So that's the kind of thing that you discuss with your physician if you have migraines, is what route would make sense for you. And how many of my kids want shots? So, antiemetics are nausea, anti-nausea drugs, and anxiolytics are drugs if you have anxiety. Now, another big mistake that you'll see in the community is that doctors prescribe these for the treatment of migraine and forget about the triptans. So these are adjuncts. They are the added drugs, not the primary drug. So if someone's very anxious with their migraine, they can get an anxiolytic, but they also need a triptan. Does that make sense? So if you would just prescribe nausea drugs, that's not enough. So this is the stuff that every speaker so far has spoken about. It's really true in teenagers as well. Teenagers don't sleep enough, and they change their sleep habits a lot on the weekends. So Friday night, they'll go sleep out till 4 in the morning, and then sleep till noon or 1 o'clock. Very bad for your headaches. Teenagers run out of the house. They don't eat breakfast. Teenagers don't drink enough water, and they're not allowed to drink water at their desks. I give a note to almost every one of my teenagers that says he or she can carry water at school, keep it on their desk, and they have unlimited bathroom privileges. Because if you drink a lot of water, you need to go to the bathroom. Exercise, exercise, and exercise. 45 to 60 minutes. Now, it's different about teenagers and adults, is that walking the dog may be the first thing that a 40-year-old has ever done for exercise. But the teenagers can do more, and they should be stressed to do more. So 45 minutes to an hour, I say they have to be sweating heavily for 30 minutes, or it's not enough to call it exercise. Walking the dog around the block is not exercise. Stress. My most stressed kids say they have no stress. So that's the toughest one. Now you turn to the parents and you say, tell me about how many activities your A student is doing. And then you find out that they're on 2 teams and the debating team, and they travel on the weekends to play hockey, etc., etc., etc. Sometimes the plates are just too full. And the kids have to have permission to drop some things. That's often the biggest fight. But if stress is the thing that's going on, you got to deal with it. New questions is bullying. Is your kid being bullied at school? It's a big thing. Another thing is your kid having trouble learning? The younger kids with headaches, that comes up much higher. Is your child just not having a good time in school? Because they're really struggling with learning? Those things need to be brought up, because if they're not dealt with, you can sleep all you want and eat all breakfast. But if school is a miserable place to be, either because you're unsafe or you're not learning, you're not going to get better. Now, how do you explain to somebody that their brain is weak? That's not. So I don't like to use those words. But what I say is people with migraines are more sensitive to either internal cues or external cues. That's something that's easier to take than migraine. Okay? So somebody with migraine senses their internal environment and gets headaches, if they're hungry or if their sleep changes. They're just more sensitive to those internal cues. Stress is an internal cue. They're more sensitive to external cues, like a bright light or loud noise, or whatever it might be. I think that's more palatable of an explanation. Now, if you're a scientist, you can explain it in more scientific terms. So you can say that everyone has a migraine threshold. Threshold is, let's say, here. If you don't have migraines, your threshold is very high, so the internal or external stimuli really have to be strong to give you a headache. If you're a migraineur, your genes put your stress threshold lower so that those things either internally or externally can produce the migraine. And part of the treatment is to raise your threshold. And that's where the exercise comes in, the eating and the writing and all that, and dealing with your stress. It raises your threshold. So that's more palatable. You like that better? Principles of treatment. Okay. If somebody has a bee sting allergy, anybody have that? Yeah. Do you carry your EpiPen? Do you wait until you're in anaphylactic shock to use it? Same thing with migraine. You've got to carry your medicine with you, and the first twinge of your migraine, you use your medicine before your stomach shuts down. Make sense? That means for school-age kids, they got to have their medicine at school. Either keep it on themselves if the school lets them, or the nurse has to have it, and the nurse has to know that if Susie comes in to see you with her migraine, you don't say, lie down, sweetie, for half an hour. You give them their medicine immediately. It's an emergency. Okay? So treating attacks at first twinge is a very important principle. Again, like I said before, treat attacks with high dose of medicine. The acute drugs need to be at their highest level, not their lowest. Now, people with migraine, George said before, sometimes don't have migraine. They have lighter headaches. If you're a migraineur, you take out your migraine medicine. You don't wait until you're sure it's a migraine, because often by then, your hair hurts, ball game over, nothing is going to work. So don't wait until you're sure it's a migraine. Use your migraine medicines right away. For this to work for the school-age kid or the high schooler, you got to get the school nurse and the teacher to buy in. If you don't have the school nurse or the teacher buy in, it's not going to work. So when you go to open school night, you have to say, my child has migraine. When my child tells you she has a headache, she's not faking. She needs to be excused and get her migraine medicine right away. So, if your trigger is avoidable, avoid it. Figure out how people cope. There are good coping skills and bad coping skills. If a 14-year-old girl has to go into bed with her parents at night because of her migraine, it's probably a bad coping skill. So assess what coping skills are in place. We talked about this. This one just shows you that not every headache is the same. Even the same person. This young woman has 4 different types of headache, and those need to be acknowledged. If somebody wakes up with a full-blown migraine at 4 o'clock in the morning, they shouldn't be taking their ibuprofen, because that headache's probably been raging while she's been sleeping. That person needs permission to go to the strong drugs right away. So, these are some preventative approaches that are beautiful. Therapy, biofeedback, relaxation, hypnosis, and acupuncture. What's common in all 5 of these is they require a lot of time and commitment from the person. So, if you're dealing with teenagers, there are some teenagers that really want to take control of their headaches. They'll do any of that stuff. And there'll be some teenagers who can't be bothered. So to offer them this stuff would be a waste of time. So the thing to do is ask. I have some options for you that don't require medicine, require your full attention. Are you willing? Is this something that's exciting to you? And what I find Because the ones that are the busiest are the ones that make time for this. There's a lot of meds, there's a lot of other meds. These are just listed alphabetically. The principle for prevention medicine is try to pick one that will kill two birds with one stone. So if someone's heavy, you don't want to put them on medicine that makes them heavier. You want to give them something to make them thin. If somebody has sleep problems, you want to give them medicine that helps them fall asleep. If someone's depressed, you don't want to give them medicine that makes depression worse, etc. So picking one of those drugs really is a combination of what will help another problem and what will not make another problem worse. So, make the right diagnosis. I think is pretty easy if you have that graph in front of you. Assess that severity and define what people want. The comorbidities are stuff like depression, anxiety, sleep disorder. Those are the three main ones that we see with the teenagers and the young kids. So, if someone has trouble falling asleep, that needs to be dealt with. If someone's depressed or anxious, it needs to be dealt with. It is a partnership. I give every one of my patients my email address. They use it. It allows for small tweaks in the plan. It also lets you know when someone's in trouble. You can come in and see you and quote unquote rescue. And it is a partnership. This is what you want to avoid. And that's somebody getting depressed from your headache burden. So I think the diagnosis is pretty easy. Stratified care means if somebody wakes up early in the morning fully sick, they have permission to use stronger drugs. They don't always have to march down the same plan. Stratified care means you have the choice of what to use and know what to use depending on how sick you are. And again, use triptan drugs early.